Hello, good evening, everyone. This is Dr. Ashanti, and I serve as the Director of Community College Partnerships for Charles R. Drew University of Medicine and Science. And you see, I'm wearing my lovely red because it's February, which is Heart Health Month, and it's also Black History Month. So we have a great conversation today. I'm joined by two wonderful trailblazers in heart health. So, but before we get into that, you guys, guess what we have going on at Charles R. Drew University of Medicine and Science? March 30th, we will be hosting Discover CDU. That is a chance for you, your loved ones, your scholars to come to CDU and discover all of the programs that we have for you. Did you know that we have three colleges on our campus? They include the Mervyn M. Dimely College of Nursing, the College of Medicine. So, yes, we have our own MD program, and we have the College of Science and Health, which houses our allied health programs. That includes a bachelor's degree in psychology, a bachelor's of science in biomedical sciences, and a bachelor's of science in public health. But you know what? We also have an associate of science in radiologic technology and the master's of science and biomedical sciences, which is number one. Hopkins is number two, but that's okay. And we also have the master's in public health, which is the program that I graduated from. So please, please, please check us out at www.cdrewu.edu to discover more about Discover CDU. So without further ado, I would like to introduce our two panelists, Dr. Yolanda Lewis-Ragland and Dr. Panteha Rezaeian. So let's jump into it. Doctors, I want to know more about your journey. Remember, I said I'm the director of community college partnerships. We are going to have some amazing scholars watching this production. Talk to us about your journey into medical school. I'm going to start with you, Dr. Yolanda.
Well, thank you, first of all, for having me. I am excited to be here talking to the Charles R. Drew University of Medicine and Sciences. And love the fact that, I went to Howard University College of Medicine, so HBCUs all the way. And the fact that it's one of the only on the West Coast, big ups to y'all, because I'm very proud to be a part of this program. I think my journey, if you will, I'll try to make this short and sweet, was rather unique, hopefully. I always been interested in medicine, well, really sciences, taking things apart, figuring things out. I'm the youngest of four, three older brothers, and my brothers took mechanical things apart, right? They would take radios apart and bicycles and try to put the chains back on the bikes and so clocks and things. And so I was always around bits and pieces, and they were almost surgeons when it came to like appliances around the house. And so that wasn't really my thing, but I was very used to it and I grew up in it. And I remember in seventh grade, I was taking a biology class, and one of my favorite teachers, and we were dissecting a cow's heart. I mean, a cow's eye, actually. The first thing we dissected was a cow's eye. And almost all the biology students kind of know that there's certain things you get to dissect: a cow's eye, a pig's heart, certain things. And so the first thing was this cow's eye. And I'll never forget, I thought it was fascinating because, we got this diagram and there were all these parts to it and you had to find the certain things. And I loved it. And I had 30 students in my class, and half the students were just disgusted by the whole concept. And I think what helped is I was the only girl growing up in my house. And so I was used to cooking with my mom. So like things like, meat and, like scaling fit, all this stuff was normal to me. So when this cow's eye was there and I had to like identify certain parts, I was very good. And I also sewed. So it's very good with my hands. So it's very like precise. Like I was very good at teasing things out and being able, and I didn't realize all of these things were going to matter at this moment. So when I needed to do this, what my teacher said was an exceptional job. And what happened is everyone in my class was like, you can do mine. Like, I'm disgusted. Like, if you want to do it. And so I remember I dissected almost 20 cow's eyes because only about 8 or 9 other students were even interested. And by the time I finished it, I had, it was perfect. It was absolutely, I'd done all the stuff and labeled them all. I was sold. I was like, anything else that we're gonna, dissect? Is there anything else I need to cut up and figure out? So by the time we got to the pig's heart, it was so fun to me. And then when I went on to, I graduated from high school and kind of decided I wanted to be a biology teacher, like, because I just loved my biology teachers. Like, that's what I thought I wanted to do. But I also wanted a break from after college. I was pre-med, like everyone else. I went to Santa Clara University in California, Northern California. But I also needed what I thought was a break. So funny that then I already felt burned out. Didn't even know what burned out was yet. But I was aware of like my mental health and emotional, needs. And so I wanted to take this break. So I decided to go off to West Africa. I became a Peace Corps volunteer. Loved it. I was in West Africa. I was in Cape Verde. And I started working with UNICEF and World Health Organization as well as I worked with an OBGYN from UNICEF as well. So long story short, it was during that process that I learned a lot about nutrition. I was working with potable water. I was working with breastfeeding and nutrition. And that became like sort of the basis of my understanding about how equity, like I actually didn't have a word for it then, right? But I was introduced to public health and nutrition and how lack of resources and lack of infrastructure really affected how people sort of grow and how community wellness can be adversely affected. And so I went on to medical school at Howard. And when I got, and the reason for me, I say it was a little untraditional is because when I was a Peace Corps volunteer, I got all of these perks, right? Before being a Peace Corps volunteer that I didn't know I was going to get when I went in. That wasn't why I went in. But what happened was I ended up I got to apply to something like 30 schools for free, and like all the fees are waived, all kinds of things if you're a Peace Corps. It's like if you're a veteran, a Peace Corps volunteer, and other like categories, you get like free applications to certain things like medical school. The fees are waived, and I had no idea. So that happened. So I applied to all of these schools, and it was my medical school interviews were so fun because I had gotten all prepared and I was dressed. I was very nervous about what they were going to ask me. And everyone told me, be prepared for them to ask you about the latest research on like HIV and all these medications. And I was all ready for that. And every time someone would open my application and they'd say, oh, wait, you're a Peace Corps volunteer? Because I interviewed in between my 2 years of Peace Corps. So it was after my first year, before my second. They said, wait, you're a Peace Corps volunteer? I said, yeah. And they said, and where are you living? I said, West Africa. And every interview was, tell me about your experience as a Peace Corps volunteer. Like, what do you do on a daily basis? And it was so fun and so easy to just talk about what I was doing. The reason I bring that up is because I want people to know that there's no traditional way to prepare for medical school. I think everyone thinks you got to be a biology major, a chemistry major, some hard science major, and then go right in, and you got to be prepared. The truth is, they really liked how well-rounded I was as a person, and that there was this unique aspect that I had brought to this experience, having been a Peace Corps volunteer. So I think, traveling to other countries, coming from other countries, speaking other languages. I was also at that time, I'm not anymore. I was also at that time fluent in Portuguese and Creole because I was speaking it every day. And so all of these unique experiences made me attractive to medical schools. And I've always said when I speak to young people about and being a mentor, don't think there's one traditional way, and don't be afraid to follow a passion. while you're interested in applying to schools, because you never know, that passion can be something that actually makes you stand out. So if you want to start a nonprofit or start a business, or whatever it is you want to do, figure out how to do it, because it can definitely make you stand out. And so for me, that was how I ended up at Howard, and sort of the beginning of my love for public health and my affinity for really talking about like health equity and inclusion and things like that.
Wow. Thank you, Dr. Yolanda. Appreciate you. Yeah, so you guys, it doesn't have to be a traditional route. So, Dr. Panteha, talk
Mhm.
to us about your journey into medicine.
Yeah, so I'm Persian. I'm from Iran. So I born there, and I knew that I'm like Dr. Yolanda. I knew that I want to be a physician or something related to the science and all of those things when I was very young. I mean, we have a lots of family members that they are physicians. So I remember I was playing, and then I was talking about I'm cutting this and sewing that. And my mom said, "It's disgusting. Stop talking like that." Later on, she said, "Okay, so you wanted to be a surgeon," because at one point I wanted to be a surgeon, which I'm telling you about that. But actually, my first few years, it was just like any other kids, very joyful, playing everything. It was good until I got 6, 7 years old. And at that time, my country attacked by another country, which we went to a bloody war, 8 years. 8 long years. I'm talking about the bombing and rockets and all of those people. It was crazy. So the life was really horrible at that time. So from very good lifestyle going to the time that for buying the bread or something, you need to stay in the line, and then you do not have all the gas all the time, the electricity was off. Sometimes we didn't have water. So it was kind of a little difficult, but I did not let any of those be a barrier to my dream. So I'm the first of the three kids. I have one sister, she's OBGYN. I have a one brother. He is actually one of those medal winner in the Olympiad, Mathematics Olympiad, International Mathematics Olympiad. Yeah, is one of the best, in the world. So, but we had a little bit difficulty at that time, but we have been able to reach our goal. Exactly same thing Yolanda said. If you have a dream, you do not let anything be between you and your dream. So I graduated from high school, very good degree with all those difficulties, but I was doing fine. I applied for medical school. Back home is different. So you are from high school, you would go to the.
Oh, did I lose you?
Can you hear
You
me?
froze for a minute. Go ahead.
Okay. So
I can hear you. I can hear you.
Um, so over there, you can go directly from the high school, pass the exam, very difficult entrance exam, going to the medical school. So I did that. Um, First year, I didn't catch it, but then second year, I got accepted, and it's one of the best school. I finished with very good credit after 7 years. It's 7 years. And over there, you can start working as a general physician until you apply for residency and wants to be a specialized. So I started doing some research. At the same time, I was doing practicing, I was doing volunteering in the refugees type of work with a lot of Kurdish people, lots of Afghani people. They migrated to my country. So I mean, I had the chance to do some volunteer job with them. I got almost accepted to the surgery because that's what I really want to, and it was my whole thing. But something happened in between, which my father actually got massive heart attack, which thanks to God, so he survived, but he went to all of those complications, and still by now, still he's dealing with heart failure and arrhythmia and those things. So it changed my mind from be a surgeon, that which was my whole dream, I was looking the things differently. I learned the cardiovascular disease is the number one killer of the human in worldwide. So no matter if you are living in Iran, in United States of America, in Los Angeles, in Africa, number one is cardiovascular disease. So I was thinking, okay, I enjoy cutting and sewing the things and put the patient back to the life, but I will enjoy more if I can save more lives, because if I'm doing preventive cardiovascular, which is a very new topic at least at that time, I can save more people. And that's changed my life. So by then I stopped just thinking about surgery. I came to United States with my family, and I did the rest of my journey.
Wow. Wow, that's amazing. Thank you. Thank you so much, Dr. Panteha. So I want to now just talk a little bit about heart health. Both of you talked about cardiovascular disease, but I want to ask you, Dr. Yolanda, why is heart health so important? And is there a disparity as it relates to cardiovascular disease?
Well, first of all, I want to say, I'm so glad your father survived. It's so interesting that we have very similar experiences. And, interestingly, while I was in medical school, my mother had, it wasn't cardiac. My mother actually had lupus. And she actually succumbed to, she had a brain aneurysm my junior year of medical school, and my mother passed. And interestingly, I tell the story actually with a little joy in my heart, in the sense that she was really my motivation for finishing medical school. I remember when it happened, I thought there's
So
no,
sorry, Dr. Yolanda.
oh, no. I mean, I remember thinking there's no way I can make it through this. Like, this is the most difficult thing in the world. This is the most important person in my life. And I remember thinking, I don't know. I don't know if I can finish. But I also remember thinking my mother would haunt me in my dreams if I did not finish medical school. This was the thing she was the most excited about, so proud, being a single mom of 4 children. I was the youngest, the only one to go to college. All of my brothers went to the military. And so I remember when I went to medical school and I thought it was going to be a difficult thing my junior year, the strength that I actually got to finish on time and like in great standing with my class was literally my mother. So it's interesting when you say this and you brought up your father, how he inspired you, or that episode inspired you to change from surgery into cardiovascular health. For me, it's the thing that pushed me to not only finish, but to recognize, and here's why I was going to tell you, for me, why heart health is so important to me. I am a pediatrician. And why heart disease is so important to me is because the disparities that exist really have to do with the disproportionate amount of heart disease that are in communities of color. The American Heart Association has a statistic that overwhelmed me, like blew me away and made me the biggest advocate for heart disease. And that is that 49% of African American women have heart disease by age 20.
Excuse me?
Yes, that makes
What?
it a pediatric disorder. When I first started to get into to heart health, people kept saying, "You're a pediatrician. Why do you care so much about heart disease?" Like, heart disease it's like an adult disease, right? It's like the 40 and 50-year-olds get it. And I said, except if you're in the Black community. If you're in the Black community, you're in the brown community, you're in communities of color or communities that are poor with low resources, it is affecting us at a much lower age, a younger age. Black women and Black men, we die younger than any other ethnicity from heart disease. And again, 49% is an epidemic. So we should be really like on top of rooftops as pediatricians saying heart disease, heart disease, heart disease for our young men and women. But when that statistic, when that sunk in, I was like, as a pediatrician, I cannot sit back and not have this conversation be in the forefront of all the conversation that I'm having with families. Because by the time people get to 40 and 50, what's happening is by the time that, because again, hypertension is a silent killer, right? So what's happening is things are going on behind the scenes with no symptoms. And by the time they have symptoms, they're finding out 95% blockage, right? 85, 95, 100% blockage once symptoms show up. And with the disparities that are happening in the hospital settings, oftentimes they get disregarded. I just had my heart health, I have an annual heart health awareness event. It was just this past weekend. And so the stories that I have people tell about themselves, many of them will say, I had tightness in my chest, I had shortness of breath, I went to the emergency room, they checked me out, and they told me it was a panic disorder. It was a panic attack.
Yeah.
And so sometimes the EKG is normal or benign. And guess what? Once someone tells you you have panic attacks, you now go, oh, so every time this happens, you sort of disregard it and you say it's a panic attack because it's been diagnosed as panic disorder.
Mm-hmm.
Well, it's for both of the people that I interviewed, and I have this part of the event called the Red Couch Conversation. They said progressively it was getting worse, but because they were told they had a panic disorder, that's all I mean, I had been contacted about transcendental meditation, about breathing techniques, all of these other holistic things because they thought they just had panic disorder. The young man, and I say young, he was in his 50s. By the time he actually advocated for himself and went in and said something is going on, he was sweating profusely, had a couple of episodes of really tightness in his chest, like actually felt the numbness in his arms, like something, this is more than panic. By the time they had he'd gone to the hospital on New Year's Eve. And the only reason he went is because his wife badgered him to the point where he was like, fine, I'm going to shut her up. Watch, they're going to just say it's a panic disorder. He didn't get released back home that night. 3 days later, he had a cath done. They found 100% blockage on one artery, 85% on the widowmaker, which is that left ascending, LAD, and a 4.5 centimeter aneurysm on his aorta. Here's what's interesting. They did the surgery, they put in the stents. After the recovery, they're having a conversation with him and they said, sir, we're looking at your heart during the surgery. You've had a heart attack before. I said, no, I haven't. I've never had a heart attack. Yeah. By looking at your heart tissue, we can tell from the scarring of the tissue that you've had some sort of incident. So it looks at least 2 years old or so. 3 years ago, he contacted me after having what he was told was the panic disorder, gripping in his chest, fell to the floor, went to the hospital. That was not just a panic attack. That had been a heart attack. And it's interesting because it's like as a physician, even a layperson, you see somebody with a scar in their arm and you say, oh, what happened to your arm? And they're like, nothing ever happened to my arm. And you're like, yeah, something happened because that scar tells me it's not like the rest of the skin. Well, that's how he felt. He was arguing with them. I've never had a heart attack. Well, with an infarct, and Dr. Panteha she's much better at explaining this, but with that infarct, the blood flow doesn't get to that heart. There's a bit of necrosis that happens at that part of the heart muscle. So when it heals itself, there's a permanent like bruise and scar tissue that's there. It's never the same. Even the electric current doesn't quite go through that muscle, right? The exact same. It's just like having a scar on your arm. Long story short, I'm so passionate about heart disease because it is disproportionately affecting Black families in the sense that, one, it's taking out our fathers, our mothers, our aunties, our grandparents. So that means our children are growing up without caregivers in their lives that really should be here watching them grow up, right? Second part is we have to change our lifestyles so that we can be the examples to our young people, right? So the better I make my lifestyle, when I increase my longevity, I'm going to increase my children's longevity. My children exercise because I exercise. My children eat right because I eat right. My children understand about de-stressing and meditation and things like that, and vacationing and taking time off because I do. So I have to practice the things that help mitigate heart disease in such a way that it becomes so normal and a part of my lifestyle that my children automatically adopt it. I don't smoke, so smoking isn't a thing that's normal to them, right? So there are things that we are just responsible for making our lives better so that our children can become better. And I think that we can show them better than we can tell them.
Yeah, I love that. And what you and Dr. Panteha stated, just about, your families and just the communities, that really pricked my ears. So, Dr. Panteha, I want to ask you something. It's along the lines of what Dr. Yolanda stated. And research has shown that people living in lower resource communities and they don't have access to healthy foods, it does correlate to poor heart health. And just with your work, Dr. Panteha, here in the Watts Willowbrook area, can you talk to us about, the work that you're doing at CDU and what you've seen in Service Planning Area 6? Which includes, Watts, Crenshaw District versus SPA 5, which is more like West Los Angeles, Santa Monica. And then I want to toss it to you, Dr. Yolanda, where in Washington, D.C., it's Ward 3, looking at like Foggy Bottom, kind of like the downtown D.C., more affluent area, versus Ward 8, Southeast DC, very similar to the community that CDU is located in. So, Dr. Panteha, talk to us about your work and things that you've seen with regard to heart health.
Yeah, sure. So thank you so much, Yolanda. And I'm so sorry about your mom, but I'm sure that it's part of your motivation is just, you can make a change and you can make others, moms and brothers and mothers and fathers alive for the other kids. So, so proud of you. I'm sure that your mom is really, really proud of you. So discussing about what you mentioned, Dr. Ashanti. So something is very important. We know by the facts that low socioeconomic, access or level is definitely related, and all the study show that without any doubt that lower socioeconomic status is related with the increased all-cause mortality and cause a specialty mortality. So it doesn't matter if you are looking at the number, both numbers shows one thing: higher socioeconomic, healthier people. Number one, because they have more access to the healthcare. Number two, because they have access to the healthy food. Look on the people that they have you're going to the, you're going to the restaurant or you are going to the fast food. You want to buy a salad versus buying a McDonald's. Which one is cheaper? Of course, McDonald's burger is just cheaper. Is healthier? Of course not. But the salad, which is healthier, unfortunately, is either same price or even higher price. So that's number two. Number three is awareness. So in the higher socioeconomic is we are all talking about the heart health and then events and all of those things. Lower socioeconomic, they do not have those awareness and I don't want to say education, but then I would say patient education. So number three, actually number four is the higher, I would say high risk attitude or behaviors, smoking, drugs, now we can talk about weeds because, vaping and weeds, there is a question mark about that, right? And the number 6 is the air pollution. Unfortunately, in many areas that we have the lower socioeconomic, they have higher pollution. So that's another thing. We know that air pollution is related. The MESA study is one of the largest study, multicentral, about the cardiovascular events. And they showed that the air pollution is related directly to the higher cardiovascular events. So, and just talking about the cholesterol, talking about the high blood pressure, talking about the diabetes, talking about the smoking, talking about the sedentary lifestyle, a very poor sleeping pattern, all of those main pillars of the heart health for primary prevention, all is higher in the lower socioeconomic, the better in the higher socioeconomic. So I want to tell you my personal experience. I remember when I was doing my first fellowship, because I did 2 fellowship, and then after that I did the clinical lipidology to just increase my knowledge about the preventive cardiovascular disease, primary prevention. So in my first fellowship, I did it with Professor Matthew Buildup in Harvard UCLA, which is, I would say, he's one of the gods of the cardiovascular disease. Everybody is internationally renowned. So he was talking about the 2 different centers. One centers with in the Beverly Hills, and other centers in Carson, near the Carson and near the Torrance in Harvard UCLA. So I used to read all the CT scan during my fellowship, right? The patient going to do the CT scan of the heart and do the angio, and then we are reading those CTs. You cannot believe, and he was telling me, because I was not practicing at that moment at Beverly Hills, he said, you will see all those, the CT angio or coronary calcium score, 000, clean, when you are reading the cases from the Beverly Hills. But when I was doing that, almost every single patient, except few percentage, they had some kind of the coronary disease, coronary artery disease, either 100%, 60%, different stages. But you could see when just in your normal life, you could see the difference. And exactly same thing happened in the area like Westwood, Beverly Hills, those areas, higher socioeconomic versus Carson or some area like Cedar is placing it. So it definitely has been confirmed by multiple numerous studies, and we know that is important, and we need to act about that right now. Even right now is late. And I want to focus on something Dr. Yolanda said, and is very important. We need to start from the childhood, not only because we need to be a good example for our kids and future generation, because starting the plaques, the small blockage in the vessels, I remember in the Harrison book, which we call it Bible of Medicine, they are saying that as young as 4 years old, those plaques start building up. So actually that was my main reason. Instead of I become a cardiologist, I decided go to the family medicine and not even internal medicine.
Wait. You mean to tell me plaque starts building up in the heart of a 4-year-old?
Absolutely. And so that was the reason I said, okay, if I want to be internal medicine, which is great, or wants to be a cardiologist, I do miss those big parts. But if I'm going to the family medicine, I need to learn about the kids. I need to learn about the mother who are pregnant. I need to just educate them. And I need to learn about the adults. So I will learn about entire lifespan, which the cardiovascular disease either starting in one of those or gradually developing by the patient getting adult. So that was the reason, and that was part of my journey. And I want to specifically focus on that because I believe it's one of those things that medical society does not pay enough attention on that. And we need to start from the child born. And then also talking about the disparity, also I want to say disparity is not only about the different races. Definitely we know about the African American, Hispanics, and South Asian. They have a higher risk of cardiovascular disease. We know about the disparity about the access. Unfortunately, those, I would say minority, they have less access. They have been diagnosed less. They have been treated less. We have many studies show they are receiving less treatment and less diagnosis. But guess what? Women has less. And then I can talk about that for hours because that's what I learned in my second fellowship with Professor Noel Berry Mears, another internationally renowned cardiologist in the area of the women heart disease. And
We're going to get there, Dr. Panteha.
yeah,
And
that's
we're
so
going to
important.
get there because as women, we are the nurturers, we're the caregivers. And it's so important that women, we take better care of our hearts. So thank you for mentioning that. Thank you. We're going to get there. We're going to get there. I promise. I promise.
This is
All
like
right.
double dutch because I'm ready to jump in, right?
All right. All right.
If
So,
you ever play double dutch, what it is this rope game, and you're jumping, and then the person jumps out, and the next person jumps in. So I was feeling like, yeah, tag me in. It's my turn because I'm so glad you mentioned so many factors, right? We talk about food access. We talk about sedentary lifestyle, which the flip side of that is getting enough exercise, right? We talk about the air quality, right? We're talking about pollution or air quality. This is why social determinants of health are so important because the fact is we talk about disparities when it comes to race because in this country, these are the communities that are experiencing the highest adversities for the social determinants of health. So it's where we are housed tends to be in areas that have electric power lines. It has others, whatever infrastructures that are polluting the air more, right? If you are in Washington, D.C., Southeast D.C. is very much different than like you said, Ward 3, Ward 1, Ward 2, where all the power plants and the electric plants, everything, and the sewage plants are all near Southeast DC. The other thing is, I taught a class on this. The zoning, the housing zoning in Washington, D.C., in the Southeast area, it's multi-family zoning. In Ward 1, 2, 3, it's single housing zoning. There was a time when the redlining, they didn't even allow Black, Irish, the signs used to say no Black, no dogs, no Irish, no Blacks, things like that, right? You couldn't even purchase a home in these areas where there were single family homes. So you were automatically placed in areas that we consider ghettoized, right? Like multi units, apartments and projects and proficiencies, all these places that, they're constantly crowding individuals. And so there's poor air quality, more communicable diseases, right? So when we talk about disease processes, most disease processes involve inflammation. That's what's happening, right? So in the inflammation process, macrophages and things like that, that's where the creation of atherosclerotic plaques start in arteries. That's why these young kids that are more susceptible and more exposed to communicable diseases are having these plaques earlier in their vessels than these kids who are not necessarily exposed to these things. There's so many parts to this, right? And so there's there's the housing, which is a part of the poor air quality, and the crowding. There's the poor food choices. I just said inflammation. When you have poor food choices, when most of the foods that you have access to are high in sugar, right? Low in nutrients. So high carbs, high trans fats, low in nutrients, nutrient density, because they're cheaper. The 10 for 10, the Debbie's cakes and the Hostess and the white bread, all the stuff that you're given on things like WIC and EBT, like when you only have a certain amount of money to feed
Right.
a family of 4 to 7, you're going to get what's cheapest. What Dr. Panteha said is, when you have a choice to buy a salad or a burger, and the salad costs 3 times as much as the burger, water costs 3 times or 5 times as much as a soda, then you're buying soda for your children and your family because it's cheaper. So there's so many reasons that it's socioeconomic, and it happens to be also based on race. But there's a part that we hardly ever talk about, that I have started talking about, and that is stress. We don't talk enough about stress, that intergenerational traumatic stress that is associated with the infrastructure of racism, the infrastructure of decreasing opportunities or not allowing opportunities for education, for housing, for job opportunities, right? All of that stuff is interconnected. So when we don't talk about stress, and all we talk about is how you're eating, and the fact that your lifestyle is sedentary, and the fact that you're smoking, why am I smoking, right? Like, what stresses am I experiencing? Why am I eating the way I'm eating? What stresses am I experiencing? That's really low. Why am I not able to sleep? What are the stresses that I'm experiencing? That is literally interconnected with all of these other factors. And sometimes I say we blame sometimes the community for these things. These are the things that you can control somewhat. What
Right.
how you exercise, because again, in a community where you can't walk because there's high crime, because there's so much going on in your community, sometimes part of your not getting exercise has to do with your environment not being safe and your infrastructure not being safe. But let's say you have control over what you eat and how you exercise and how you sleep, which we all know you don't fully have control. What you don't have control over is those stressors that you're experiencing from the institutionalized racism that is intergenerational and multi-generational. So I'm so glad we talk about some of these factors, but I don't hear us talking about stress enough, that we often act like that's not a part of it. And that's a huge part of it.
And that's a great segue into what both of you are talking about as it relates to heart health and women. We are stressed. I know we're on a webinar. I know we're broadcasting to a lot of people, but I'm just gonna say it. As women, we are stressed the hell out. We have kids, sometimes raising kids on our own. There are just so many things with racism, sexism, all of that. How can we, Dr. Pantia, with your work, especially with immigrant women, we haven't even touched that. Women come into this country, stressors, all of that. How can we talk about stress, women, and heart health? Dr. Pantia and then Dr. Yolanda.
Sure. Thank you so much, Yolanda, talking about that stress, because I'm 100% agree with you. Is one of those very important issue that we are not talking enough about that. Number one, because um, the okay, so media or industry trying to let us think, okay, so stress, yeah, it's actually a little bit of stress is good for you. Yes, a little bit if you want to study for your exam, but not too much. And they are trying to say, okay, lifestyle is stressful. I mean, we are living a modern lifestyle, which we are rush, 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 and there is competition, and you need to be on top of your line to be able to have something to say, right? As an immigrant, I will feel it much more probably because I was trying to get to my residency. I had many younger generation coming from medical school, sharp, fast. I was out of medical school already for few years, and because I was waiting for my immigration process to be able to come here. So I was able to see the difference. So it was more stressful for me because I was not as fast typer as the other new young generation. So it was a stress for me and so many other things. But talking about the women versus men. So there is different levels and different stages that we can talk about that. Number one, the symptoms. The women cardiovascular symptoms are different from men cardiovascular symptoms. We didn't know that for many years. Why? Because the symptoms that we learn and then we just, we conclude that is the cardiovascular disease symptoms coming from the studies, which mainly was man dominated, so dominated. So it means that most of the subject or the people involved in those researchers, it was male versus women. I mean, male versus female. Why? Because for many different reasons, we have more recruiting the male into the researchers. So the result was a male pattern cardiovascular disease symptoms. Those Hollywood type of chest pain, boom, left side chest wall pain, chest pain, and then you drop on the floor is the male pattern. I'm not saying the female does not have that, but I'm saying that the female usually have more kind of non-specific symptoms. Could be just too much fatigue, could be lightheadedness, could be dizziness, could be more kind of stomach issue. The men also can have that, but those heartburn, we can see it more in women. Lightheadedness, dizziness, very significant fatigue is more in the women. We learn more after the Professor Barry Mears and some other doctors they start seeing a difference that even though they have been able to improve the cardiovascular disease control, the number of the women getting the cardiovascular death was increasing, the men was decreasing. So they were saying, okay, there is something going on. So then they figured out something that the men has different pattern of symptoms. Number two, the pathology of the cardiovascular disease, and right now I'm talking about the blockage and the buildup of plaques in the vessels in the men is different from women. The men has mostly in the bigger vessels. The women, we have it in the smaller vessels, and we call it microvascular disease more in the women, and macrovascular, which is in the bigger vessels in the men. So that was the reason they were putting the women with the chest pain, and I'm talking about the time we did not have the troponin test. I remember 24 or 5 years ago when I was in the medical school, we were just putting the women with the chest pain in the angio, in the cath lab, and just injecting the dye, and it still shows the vessels are clean. And that, okay, so you have a cardiovascular disease, go home. And then many women, actually, because of those studies, which were mainly male dominated, they were sending home even before going to the cardiac cath lab, because yes, you have a stress, you are panicking, you are fighting with your husband, and you are here because either wants the more attention or you have anxiety. I remember that very clearly when I was back in medical school, because at that time they didn't know better. They did not have those information we have right now. The other things, okay, so not only we do not have enough, I mean, right now we have, but at the time we didn't have enough information about the symptoms. We do not have same pathology or cardiovascular progression in the male and female. Also, we do not have enough in the difference of the diagnostic. The EKG considered abnormal in the male, not in the female is different. So those threshold, those criteria in the lab, we will consider as a marker to diagnose patient with cardiovascular disease is different from the men and women. So in the number is abnormal for women, it does not consider abnormal for men. So if we have those thresholds built up based on the study comes from the male dominated studies, we are missing the women, which they have abnormal results. But if you look at on the range, which is good for male, you will miss them. You will miss them. You send the patient home.
My
you have
goodness.
a check, but the result is normal. Your EKG is normal. Your blood test is normal. And we did the cardiac cath, and your cardiac cath is normal.
And
Yeah,
you're a woman and you're emotional. And so
Hysterical.
again, hysterical,
absolutely.
histrionic, right?
Yeah,
And
yeah,
and to your point, Dr. Ashanti, you already come in telling us how much stress you're under because
absolutely.
you're the caretaker, your husband, your children, your job, you're wearing multiple hats. So you've already sometimes set the provider up for this understanding
Diagnosis.
that you're already stressed, right? And
Yeah,
so when we see, and unfortunately to their benefit, when they see these normal tests, but you've already told us you're stressed, well, then there you go. It's anxiety. This is why this is a commercial, really, for getting involved in research, right? That we need more women getting
absolutely.
involved in research, and we need more diversity in research because the
Absolutely.
truth is some of our Black men also don't have the same symptoms as,
No,
like I say, that PSA, that heart pain, clutch, pain down your arm, that for a long time was a white male PSA for their heart symptoms. Even our men didn't, even our Black men didn't have the same. Like the fact that we have now more diversity in research, we're showing that there are several different symptoms. With another thing with women is sometimes it's lower back pain. It's
mhm, mhm.
fatigue. Like I said, it's indigestion. That's so common in women, right? Lower
Yeah.
back pain. I just feel tired. I have a little indigestion because I don't think I'm eating right anyway because of the way I'm stressed. I kind of eat, crazy. All of that. And guess what we do? We lay down because we don't feel well, and then we don't wake up because we had that silent heart attack or
Okay.
even a stroke. So that's the reason that we are often talking about getting involved in research, but it's so important because you'll expand the criteria and understanding of what the signs and symptoms are because the diversity matters. It will expand the different criteria we're looking for in the blood test, the troponin, all this stuff, that stuff, it looks different when you have more diversity. But
Absolutely.
for a long time, it was based on how white men showed up in the emergency room with heart symptoms. And it's because the world was centered, at least in America, on white men. Then they began to look at, Black men, white women, Black women, Asian, all the colors. But the point is, it's the more diversity that we have in research and in studies, the more lives we'll save because we'll understand that there's diversity in symptoms and diversity in treatments, just like there is diversity in people. So I'm so glad that you're pointing that out because that's actually in the conversation that I had in my event. that was the conversation I had in my event, was that men and women definitely present differently.
Yeah.
Wow.
And then
Oh, go ahead, Dr. Panteha. I'm sorry.
Yeah, one thing I want to also mention that the difference as far as the awareness about the cardiovascular disease is that even that there is a disparity in the cardiovascular awareness between different, groups. So we know that, for example, Hispanic and African American community, they know less about the cardiovascular disease and importance, and then it's the number one killer, because we are not giving, I mean, not we, but then the community, the media does not give them enough education. We need to work on it. And that is one of the reasons I want to talk about that, because the medical student and resident at the CDU, they have this opportunity. And I think, and I'm sorry if I'm talking a little bit in the bigger words, but I think that's their duty to their society, not even here in Los Angeles, in the around here, anywhere they will go and they will practice. That's their job, to make sure that they are spreading the words and increasing the awareness, because that's why we can, that's how we can decrease the cardiovascular disease, which is number one killer of the human. Number two, we need to let the people know, go to see your primary care doctor and detect all those risk factors before something happens. Because the most of the chronic disease, they do not have any symptoms. I'm always telling my patient, is like a termite inside your home, is eating entire backbone of your home. And one day you just need a small little rain, then your whole home collapse. It's not like a cold symptoms. Your symptoms start when you get infected. It's not like car accident. You have a symptoms when you have an issue. The disease, high blood pressure, high cholesterol, elevated blood sugar, which diabetes, all of those things start many, many years before the heart attack starts. But guess what? You are going to seeing your doctor for your annual wellness. If you are smart enough to do that, your doctor say, by the way, your blood pressure is elevated. Make sure you do these, do low salt, and then you do exercise, and then you take your medication. Your cholesterol elevated, you need to take your statin. You can, diet and exercise plus statin because your number is high. I do not feel anything, doctor. Why I have to take the medication that my friend or my neighbor telling me I'm getting the body ache on that? Come on. I see that untreated high cholesterol will end up the heart attack, and one day you are not waking up. But they don't see that because they have no pain, they have no symptoms at the moment. As a doctor, that's our job, to increase that understanding in our patient. Actually, I had one patient a few days ago. It was not young, it was 60 years old gentleman. And he was, but he was a gentleman. Actually, he was Persian, so there was no kind of the language barrier. I remember I was telling him, you need to do this for your blood pressure, you need to do this for your cholesterol. And I said, doctor, I'm really feeling well, and I'm, exercising every day without any chest pain. Guess what? A few days ago, he admitted to the hospital. Thanks to her wife that pushing him to go to hospital, he had the STEMI, which is one of the worst heart attack, and was 100% blockage in the widow maker vessels, and 60% and 70% on two other main vessels. So all three vessels had the blockage. But because he did not want to listen to the doctor, say, please take your medication. He was saying, I do not have symptoms. So number one, please make sure you go to see your doctor at least once a year. If you have no symptoms and you are feeling you are healthiest person in the world, please still go to see your doctor, because your primary care doctor can detect all of those wrong things that you don't see because you do not have the symptoms at this moment, and can prevent the future heart attack and stroke. And there is a treatment if you act right now.
So I'm going to add to that. I think another responsibility of ours, just like you said, it's a responsibility of ours to have our medical students, and our residents really understand and learn so that we could put this forth in the community. I think there's some other responsibilities of ours as healthcare workers that I don't think we are living up to. One is preventive medicine, right? So I don't think we're talking enough about eating right and healthy lifestyles, so that by the time we're talking about medications, people really have not heard enough about how to prevent them from getting to that space. So now they're a little hesitant because that's in their minds, it's the first thing that we're offering. The problem is we really should have been talking from childhood about the ways you're supposed to eat to prevent heart disease. Actually, we should literally be saying heart disease is the #1 killer of all Americans. To prevent heart disease, it's the #1 killer, not even just all Americans, like Dr. Panteha said, worldwide. But if it's the #1 killer of all Americans, then it's the #1 thing that we should be advocating against from childhood. We should be saying that from childhood. Now, there are foods, and I'm going to say foods in quotations because they're not really food. They don't have any nutrients to them. There are substances that we're allowing our children to eat. I don't even want to get into different brands because, it's not even about that, but Pop-Tarts and I mean, there's just junk that's not food, right? It's
High
not
fructose corn syrup.
high fructose corn syrup that we're constantly feeding children because it's convenient, because it's quick, because it's really a disservice to our children. Then they're growing up with these convenient lifestyles, and they get into their own teen years, right, where they're responsible for feeding themselves. And guess what they're eating? Hot Pockets. They're eating nuggets and this is what they're eating because it's quick and it's fast. Again, it's cheap. Then they become adults. They're in college. They're eating ramen noodles and just junk. Like, it's not food. Very few fruits and vegetables. Very little fiber. Very little of the things that actually are good for heart health. And then you want to tell them at 40 and 50, you need to be eating more vegetables. You need to be eating, and now I'm saying you need to be drinking all the water, but they've been drinking soda and juice and Kool-Aid and all this junk for their entire lives. And we as parents are the ones pushing it on them. That's part of the problem, right? So we don't talk enough about nutrition. So people resent us as physicians by the time we're telling them to take medications. I'm just going to be honest, and we got to be more proactive about telling them what they should eat to avoid medications. But guess what? Once the medications are on board, yes, now this is where you are, and this is what we need to do. So that's, I believe, one part of it. There's the medications, but the other part of it is, how do we address and reduce stress? Because the thing is, that's still there, right? So what are we doing? And one of the things I want to end with is that I am an avid advocate and practitioner of something called transcendental meditation. And transcendental meditation is very different than other meditations, mindfulness, the things. In fact, it's the only meditation that has been actually endorsed in a policy statement by the American Heart Association that says that the scientific studies has shown that transcendental meditation actually lowers blood pressure. And it lowers blood pressure. There's other side effects, like improves cognition, improves sleep, helps you with cravings, things like that. Interestingly, most things that I talk about that has side effects, I have to rush through the side effects and whisper them like in the commercial. You know, brrr, like you don't want to talk about the side effects because they're all the bad things. This is the one thing that has all the effects are positive effects. There's no negative effects. So I'm shouting from the rooftops. But not only do I practice transcendental meditation, I became a transcendental meditation certified teacher because I believe that much in it. And it's the one thing that I can say I don't feel bad giving to patients because, in addition to, and one of the things Dr. Panteha knows, everybody doesn't respond to all the medications. That's also part of research. We're finding that everybody, for whatever reason, African American, a lot of times we don't respond to certain blockers and some of the, inhibitors and, some of the statins. It's not that we shouldn't take the medications. We should, and we should be compliant. But sometimes people's complaint is even in their compliance, they're not always seeing the effects that they should see because sometimes the medications aren't effective on all people. Again, why research in diverse populations is important. But transcendental meditation, and I'm sure other wellness, activities that lower stress can be extremely important on top of, not in place of, that's not what I'm endorsing, but on top of all of that, eating right, getting a good night's sleep, getting some regular exercise. And when I say regular exercise, how do we do that? Make it fun, right? It doesn't have to be running, you're on the treadmill. Get in walking groups, do Zumba, right? Anything that's I have a Peloton. You have like a Peloton community. You get to be interactive. Make it fun. Make it give yourself some accountability, but you got to get moving. Just walking groups are fun, but biking groups, any of that. But getting that exercise in, getting a good night's sleep, eating right, and de-stressing, you have to do all of the things. And yes, medications that are prescribed to you, be compliant. But our number one goal is to try to get you off the meds if we can.
Absolutely.
Because you're doing all the other stuff, it's a possibility that you may not have to be on the meds. But once you're on them, you have to be compliant. And the last thing I want to say is that's the hard part. We don't always get to say, or we want to say, see your primary care. See your primary care, but that's another barrier because not everybody has insurance and not everybody has a primary care. And often they're using the emergency room as their primary care. And that's where, therein lies the problem because we can't keep trying to treat you for a chronic illness in the emergency room, which is designed for urgent, emergent issues. So you're not going to get the diagnostic tests you need. You're not going to get the wraparound services. You're not going to get the continuity you need if you keep showing up to the emergency room. So again, we got to work on the disparities in these communities so that they can have a primary care doctor who then learns enough about them to help them advocate for themselves so that they can get these diagnostic tests that are life-saving and life-prolonging done. But therein lies, again, the conversation about disparities, because in these low socioeconomic communities, we tend to have less insurance coverage, or I won't even say no insurance. If you have low insurance coverage, you get less diagnostic tests, you get less treatment, you get less diagnoses, right? Because your insurance isn't that great. So they're not really going to go full force for you. And so all of these things are barriers that we just have to work on. And I think that's a part of our responsibility in the medical community as well.
Yeah, and I think that's great, and that's a great note to close on because it lets us know that we're all needed. So even with me as a public health professional, it's about educating the community, going into our churches, going into our temples, and really educating people about their health. The work that you're doing, Dr. Panteha, with immigrant health, also the work that you're doing with women. I think that's amazing. The work that you're doing, Dr. Yolanda, in our community as it relates to heart health and with our young children. So that's very important. So you all, I just want to thank you. Don't go anywhere, panelists, but to our audience, thank you so much for joining us. We did go over time, but you know what? This conversation was great. It made my heart happy. And I just want to encourage you to get screened. I don't care what it is, get screened, go to your primary care doctor. If you don't have one, ask somebody, ask someone to take you to the doctor and go ahead and get your test. When you guys were talking about the fatigue, I'm thinking like, uh-oh,
Mhm.
they go ahead and get checked. So just feeling nervous, but that's what we need to put the fire under us to go ahead and make sure that our hearts are healthy. So we want to unlock heart health. So thank you so much. Once again, my name is Dr. Ashanti Carter, and I serve as the Director of Community College Partnerships at Charles R. Drew University of Medicine and Science. And I'd like to thank you for joining me in the Lion's Den, and I'll see you next time. Take care. Bye-bye.
Bye-bye.